Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
Hi, I'm Pat Loehrer. I'm Director of the Center of Global Oncology and Health Equity at Indiana University.
Yes, and hello, I'm David Johnson. I'm at UT Southwestern in Dallas, Texas.
And welcome to another version of Oncology, Etc.
Yeah, great guest today. Before we get started with our guest, though, Pat, what are you reading these days? What can you recommend to me?
Well, I'm reading Jamie Raskin's book, which is about his son and about the insurrection. It's really a wonderful read so far, particularly I think about the family nature and how much he deeply respected his son, who unfortunately committed suicide.
Right before one of the impeachment trials, as I recall, right?
It was right before the January 6th insurrection.
Yeah, terrible situation. You know, I have a book I've been meaning to recommend for a while. It's one that I've given to all the chief residents I've worked with over the last several years. And today's guest made me think about this book. It's entitled Osler, Inspirations from a Great Physician. It's written by Charles Bryan, who's the former chair of medicine at the University of South Carolina in Columbia.
You trained with Osler, didn't you?
I was a couple years behind him. He was my senior resident. It's really, for anyone who's an Osler file, it's a great book to have, but even if you're not, it's got some wonderful lessons to be learned about how to interact with one's colleagues and a lot of information about leadership, which is why it made me think of today's guest, Dr. Deborah Schrag, who we're really excited to welcome to Oncology, Etc. Dr. Schrag is the chairman of the Department of Medicine at Memorial Sloan Kettering Cancer Center in New York. She's a highly accomplished healthcare leader, clinician, researcher, and an expert in public health and population science. Deborah received her medical degree from Columbia University and completed a residency in internal medicine at Brigham and Women's. She obtained her medical oncology training at Dana-Farber in Boston and also received an MPH degree from the Harvard School of Public Health. After a brief stint on the faculty at DFCI and Brigham and Women's, she joined the Division of Gastrointestinal Oncology at Memorial Sloan Kettering, where she was an associate member and associate professor of public health and medicine. In 2007, I believe it was, she returned to Dana-Farber and Brigham, where she continued her work focused on improving the delivery, quality, and effectiveness of cancer care. While there, she served as chief of the Division of Population Sciences until this past year when she returned to Memorial to chair the Department of Medicine. I also think she's the first woman to hold this position, but we'll learn about that momentarily. Deb is internationally recognized as a pioneer for her work engaging patients in reporting outcomes as a way to improve care. She has led pragmatic trials using informatics strategies to optimize patient and clinician well-being and the efficiency and quality and equity of care. In short, she's a true superstar, leading a department, the major department, in one of the world's foremost cancer institutes. So, Deb, welcome to Oncology, Etc., and thank you so much for accepting our invitation. You know, this is a relatively new oncology podcast, but already we're known for our incisive, deeply penetrating questions. So I have a question for you to start off. Do you have any carpentry skills?
Absolutely none whatsoever, Dave. None.
I'm disappointed. It's my understanding that Schrag is German for cross or a slant in people who build cross-legged tables. So I was hoping you might do something. My house was destroyed recently, and I'm looking for replacement furniture, and I was hoping you might be able to help me.
I apologize, but I'm not going to be able to help. The name, you're correct, though, Dave. It is a German name. So my family does hail from Germany, and they made malt, which is the major ingredient in beer. So I'm not sure where the name comes from, but they ran malt factories and shipped malt all over to all the beer, before there were all the craft beer distilleries. That's what they did.
That may come in handy by the end of this podcast, by the way.
Could be.
Well, speaking of your family, tell us a little bit about your background and where you were raised and your family members.
Sure. So I'm glad you asked that, because I really have been very influenced by where I grew up. And as I think about it, experiences that go back to first grade got me where I am today. So I am from New York City. I grew up in Manhattan in the 1970s. And as you may know, that was a pretty rough time in the history of New York, what's often referred to as the bad old days, although it didn't feel that way to me. But I started out attending New York City public schools. And at that time in my neighborhood on the Upper West Side of Manhattan, my first grade class had about 45 students, one teacher. There were about 5 or 6 of us who spoke English, and everyone else was a recent Puerto Rican immigrant. And I pretty much sat in the corner and read to myself. Now, I didn't stay in the public school system for long, but I saw in first grade how things weren't fair. And I saw and felt my own privilege acutely. And even as a little kid, I had that sense. Eventually, my parents transferred me to private school later on, and there were kids in the neighborhood who didn't have the same privileges that I did. But living in New York, you walk around, you're confronted with disparities every day. We still see it today with homelessness on the streets. At that time, there was lots of alcoholism and use of drugs, and there were 2 blocks north that were safe to walk and 2 blocks east that were not safe to walk. So this really stuck with me from a very early age. As a student in summer jobs, I worked lots of interesting jobs. I started at 14 scooping ice cream at Baskin and Robbins. I worked at a famous deli in New York called Zabar's, selling coffee. Lots of interesting jobs that I worked during holiday and vacation times. But one of my first jobs was working in an organization called the Floating Hospital, which was a big old ferry boat that circumnavigated Manhattan. And it provided a summer camp. And we would take 1,800 people on a boat around Manhattan every day. And my job was to do lead testing. And I learned how to stick kids, test them for lead, because there was incredible amounts of lead poisoning in New York City in the early 1980s. And then we would work on tracing the kids. And these were toddlers, 2-year-olds, 3-year-olds. There were many families who were living in homeless shelters in New York City in the early 1980s. And that was really the beginning of my interest in public health and inequities, and really the marriage of medicine and public health. That had a deep and long-lasting impression on me and really stayed with me throughout my career. That early experience, I think it propelled me into medicine, into medical school, and also to marry medicine and public health.
Tell me a little bit, Deb, about your parents.
Sure. My mother was born in the United States, and she was a teacher who many years later, after having 3 children, went to law school, and she became a litigator. And actually, her boss was Rudolph Giuliani. My father is a child of World War II. He was a child of German Jewish parents who had to flee the Nazis. Probably the most interesting story is my paternal grandfather was an OBGYN. So I am a 5th generation physician. My paternal grandfather was an OBGYN at Charité, which is a very famous hospital in Berlin. He was the head of OBGYN there in the 1930s, but I think he was half Jewish. And the Gestapo asked him to leave, and he had to leave. He was an expert in version, which is essentially flipping babies in the setting of placenta previa. He then left to Lebanon, where he was in the French resistance and had a thriving OBGYN practice in Beirut, Lebanon during World War II. And at night, there was a curfew on, and he was part of the resistance and passed secrets around from the Russians to the French. So very dramatic. My father was born into this setting and arrived as a new immigrant to the United States in the 1940s, where it was very hard to be a child whose parents had a German accent, given the prejudice against Germans at that time. But also went to New York City public schools, had tremendous opportunity. So really kind of the classic New York immigrant success story, arrived to the United States with the shirts on their back and managed to work their way to a better life and achieve success and good education through public education for all their offspring. I will also say that my father had a public health stint. He worked in North Carolina as an alternative to going and serving in the Vietnam War. He was in the public health service, and he worked in North Carolina in the textile mills and worked on a disease called byssinosis, which is also known as brown lung, and it's an occupational health disease that affects textile mill workers. As a child, I spent many dinners hearing about byssinosis and brown lung and black lung, and I think at an early age really came to understand how the world wasn't fair and how it was instilled in me early on that it was important to work to try to make things better, particularly for people who didn't have privilege. And I think when you come from an immigrant family and you realize how much privilege has been bestowed on you, that really leaves an indelible mark. I have to say, as chair of medicine at MSK, it is staggering to me the proportion of faculty here at MSK, but also at Dana-Farber, where I worked previously. We have lots and lots of immigrants who've been able to accomplish just amazing things through just motivation and drive and energy and creativity. And so I'm a big believer in how much immigrants power this country.
Deborah, are your parents still alive?
My parents are still alive. They're both in their early 80s, and they both still live in the Upper West Side of Manhattan. So I'm very privileged and fortunate to have living parents.
I can't imagine the pride that they have for you.
I just want to jump in and let our listeners know that Deb mentioned Charité in Berlin. That's the home of multiple Nobel laureates that all of us would know, like Ernst Chain, who was one of the individuals involved in the development of penicillin, but Paul Ehrlich, Robert Koch, Hans Krebs, and for cancer doctors, Otto Warburg, among others. So it truly is a world-renowned institution.
Well, my paternal grandfather was famous for this technique called version, which essentially involved putting your stethoscope next to the uterus, figuring out where the placenta was, and then essentially trying to flip the baby without disrupting the placenta or causing any harm, which required incredible skills with a stethoscope because you had to appreciate, I guess, the placental vessels. I'm not aware that this skill is still in existence. It was an important skill to have in the 1930s when, if you did a C-section, there was a high probability of endometritis. So you could save the baby, but you would often lose mom to endometritis. Or you could save mom, but you might not save the baby. So at that time, it was a big deal, but thankfully no longer.
This is why we call it oncology, et cetera. Our listeners didn't know they were going to get OB information in this particular podcast.
Or a digression on the history of medicine. I do find that, I am inspired by the generations that came before me. I think it's also true that there are many physicians who are first-generation physicians in their family, and some of us are privileged to have lots of healthcare professionals and sort of feel it as a calling.
So, Deb, I think of you with many, many talents, but one of the things that I think stood out to me is many years ago, you were in the van talking about financial cost of healthcare. And I remember a very influential paper you wrote in the New England Journal talking about the cost of treating GI cancer, colon cancer in particular. But where did your interest in that particular aspect of healthcare begin? What was the stimulus there? I mean, you obviously had a lot of stimulus from your family. What else?
So that's really interesting. And this is a little bit of a history of oncology. At that time, I was an assistant professor, an assistant attending on the GI oncology service, seeing lots of patients with colorectal cancer. And we were working on a clinical trial of a drug called Imclone C225. And that was the name of the protocol. And we were putting patients in that clinical trial. And you know what? This drug was working. We were getting excited and the drug was moving ahead. And we looked at the phase 1 data and we launched the phase 2. And we had meetings with the research protocol nurse and the research assistants, team meetings. And I would say there were about 50 people who were aware between the GI oncologists and the nurses and all the research assistants. You guys know that it takes a village. And even though the villages were smaller then and it wasn't a particularly large trial, there are many, many people involved. And everyone had the sense that this drug might be working. And just for context for our younger listeners, this is back in the early aughts. And basically, the drug that we had to treat colorectal cancer was 5-FU in many different formats and irinotecan. And that was it. Some people thought mitomycin might work a little bit, but it was so horrible that it really barely worked. But that was what we had in our bag of tricks. So the fact that we had this Imclone drug that eventually came to be known as cetuximab was remarkable. So here's what happened. It turned out that this is the drug made by the company Imclone, and there was some shenanigans, some insider trading. And one of the people caught up in the insider trading, in addition to some people involved with the company itself, was none other than Martha Stewart, sort of the famous homemaker who still publishes magazines to this day. And you may know that she actually did some time in federal prison as a result of insider trading on this drug. And I remember being a junior attending and all the people involved in the trial and all the cancer professionals, we all knew this was working, but everyone respected the confidentiality of the situation, of the patients, all the integrity that goes into academic medicine. And I remain inspired by all the integrity of all the professionals, the doctors, the residents. These were not affluent people. I can tell you we were not paying research assistants a whole hunk of money. They investigated every trade made by this company. There were absolutely no shenanigans or improprieties from the hardworking folks who helped bring this drug to market. So as this was going on, we had many patients who were not eligible for the trial, who were interested in getting the trial. So of course we followed as this drug got FDA approved and came to market. And you could check me, but I believe it was February 2004, it was FDA approved. And it came out with a huge price tag. It was approximately $10,000 per month. And I was mad because I was taking care of regular New Yorkers at that point. I had public school teachers, I had patients on Medicare, and they couldn't afford the 20% copay. Because $10,000 a month for cetuximab, if you have a 20% copay and you're a New York City public school cafeteria worker, not yet eligible for Medicare with a typical plan that a New York City public school system employee would have, that was $2,000 a month. And that did not work for one of my patients who was essentially what we used to call a lunch lady. And I was so mad that I decided to channel that anger into writing what is, I think, a perspective for the New England Journal called The Price Tag on Progress. I wrote that piece. I know that many, many people and many of my esteemed colleagues have continued to work in that area and do research on the economics of drug pricing. And there are many, many experts. I didn't stick with that. Not that it's not interesting and not that it's not important. It's incredibly interesting and important. But I felt that the solution needed to happen in the legislature, state legislature, federal legislature. I think that this is about social policies and we need to advocate for appropriate health insurance programs to make it possible for people to get coverage when they have catastrophic illness, and that we need to think the entire approach to drug pricing in this country. I still think that's important. I'm not convinced that what we need is more research on the topic. I think we need more policy making and laws on the topic. And I think we're still dealing with this. I'm sad to say that it's been nearly 20 years since I wrote that perspective, but I think it was motivated by frustration, not being able to get my patient what she needed. and many patients thereafter, and just the incongruity of some people benefiting from insider trading and all the good people who were doing the right thing.
I just want to throw in one thing, if I can't. Len Saltz, who's one of your partners, was a PI of that trial. He presented at ASCO talking about ImClone C225, and ironically, it had a 22.5% response rate. And Len said, it's a bummer that ImClone didn't call it C995.
You have no idea how often we used to talk about that and joke about that in clinic. I have another good story about that drug, which I think really illustrates something I believe. And I think it's actually something that Osler said, but it's also something that I have to say I learned from both of you. And it has to do with listening to your patient. So I had a patient named Matthew, who was a young man, 34 years old. And he walked into my clinic with a diagnosis of diffuse metastatic colorectal cancer with multiple bilateral pulmonary metastases, which came to light when his tennis game was off. And he was at that time an early employee of a newly started company called Google. And he was working on advertising algorithms. And Matt got the drug cetuximab. And unfortunately, he was on it for quite some time. He was on it for about 5 or 6 months, but eventually it was pretty clear that we were coming to the end of the road. And he and his wife planned a vacation, and this was part of his end of life process planning. It was their 5th wedding anniversary in the Berkshires. And we worked so hard to get Matt to the Berkshires, to a beautiful inn. And on Saturday night, my pager goes off, and Matt cannot sit up. He's weak. And he'd been complaining of terrible fatigue for weeks to me. And I really hadn't quite figured out why Matt was so fatigued. I mean, I just didn't understand it. And we get him to this inn, and I get a call from the Berkshire Medical Center, a small community hospital. Dr. Schrag, your patient is here. He's so weak he can't sit up. What's going on? And the ER doctor says, well, he has a Schwastik sign, which is a sign of severe hypocalcemia. I said, so call me back with the calcium. The calcium is low. Well, I think those of your listeners who are closer to medical school know that when the calcium is low, you got to check the mag. And Matt's magnesium was 0.2. And he got some magnesium in the Berkshire Medical Center. And all of a sudden, he felt great. And he was able to go on and enjoy the second half of his 5th anniversary weekend at the Berkshire Inn. And he came back, and I felt terrible because he'd been complaining to me of fatigue for 6 weeks. And I hadn't checked his magnesium. I was like, 50 bilateral pulmonary metastases on chemotherapy. That's the fatigue explanation. Suffice it to say that we went on to start checking magnesium on everyone getting cetuximab. Now, mind you, the drug is FDA approved and FDA labeled at this point. So we start checking magnesium. We find that it's low. I start getting on the phone and calling my mentors. I called Dr. Bob Mayer, who was the head of my fellowship director and was like a revered mentor to me. Hey, Bob, anyone up there in Boston have low magnesium from cetuximab? We don't check magnesium. Could you check? Started calling around, and that's a great example of the community of oncology. We are a community. Just started working the phones and calling friends and say, you guys checking magnesiums on any of these folks with cetuximab? Suffice it to say, we figured out that there are EGFR receptors in the ascending loop of Henle. So again, back to biology and pathophysiology, and that the drug cetuximab was blocking reabsorption of magnesium in the kidney, and that cetuximab caused a terrible magnesium wasting. Oral magnesium did not work. You had to give it intravenously repeatedly, and we helped eliminate fatigue for a bunch of patients. About 6 months later, I showed up at ASCO with these little cardboard slides and a little poster back in the corner and put up our little case series, very little. But I'm proud to say that we changed the label of cetuximab, and it's now on the label that it causes hypomagnesemia. It might be one of my more cited papers, paradoxically, but I think it's a principle that really has stuck with me, and I've tried to impart it to all the students and residents and fellows. Listen to your patients, because I think it comes from OSLR. They're telling you something. We have to pay attention. And again, I have never forgotten that, but really listening and trying to figure out how we can use our understanding of pathophysiology and what our patients tell us to ask questions and not just accept dogma and try to figure out what we can do. And, I couldn't figure that out on my own. I happened to find a really smart nephrologist who happened to be able to sort of go to animal models and knew the right studies and the right people to talk to.
It's one of the reasons why we are a multidisciplinary specialty, and we use the expertise of our colleagues. And I think that's such a wonderful example of listening to one's patient, and it really profoundly impacted our understanding of how that drug works and renal physiology, actually. That wraps up part one of our interview with Dr. Deborah Schrag, Chair of Medicine at Memorial Sloan Kettering Cancer Center. We hope you've enjoyed learning about her background and early career. In part two of our conversation, Dr. Schrag will discuss her programmatic goals at Memorial Sloan Kettering, the importance of mentorship and leadership, and what it means to have joy in the profession of medicine, and frankly, much more. So please be sure to join us. As always, we want to thank you for tuning in to Oncology, Etc., an ASCO educational podcast, where we will talk about just about anything and everything. So if you have an idea for a topic or a guest, please email us at education@asco.org.
Thank you for listening to the ASCO Education Podcast. To stay up to date with the latest episodes, please click subscribe. Let us know what you think by leaving a review. For more information, visit the Comprehensive Education Center at education.asco.org.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.